Mixed connective tissue disease, MCTD, undifferentiated connective tissue disease, UCTD, and overlap syndrome are all autoimmune conditions that feature characteristics of multiple connective tissue diseases, CTDs. However, they have distinct features. Mixed connective tissue disease, MCTD. Definition: MCTD is characterized by the presence of clinical features of multiple connective tissue diseases, particularly systemic lupus erythematosus, SLE, scleroderma, and polymyositis. The hallmark of MCTD is the presence of high titers of anti-U1 ribonucleoprotein, RNP antibodies. Clinical features: patients with MCTD often present with features such as Raynaud's phenomenon, swollen hands, arthritis, myositis, and esophageal dysmotility. Pulmonary involvement, e.g., pulmonary hypertension, is also common. Prognosis: the course of MCTD varies, with some patients developing features of one particular CTD over time, while others continue to display features of multiple diseases. 2. Undifferentiated connective tissue disease, UCTD. Definition: UCTD is diagnosed when a patient has symptoms and signs suggestive of a connective tissue disease, but does not meet the specific classification criteria for any well-defined CTD, e.g., SLE, rheumatoid arthritis, scleroderma. Clinical features: symptoms can be mild and include arthralgia, fatigue, Raynaud's phenomenon, and low-grade fever. Serologic markers such as ANA, anti-nuclear antibodies, may be positive, but without specific autoantibodies like anti-dsDNA or anti-Smith. Prognosis: UCTD may remain undifferentiated indefinitely, or it may evolve into a well-defined CTD over time. Some patients may experience spontaneous remission. 3. Overlap syndrome. Definition: overlap syndrome refers to the coexistence of features of two or more well-defined connective tissue diseases in the same patient. For example, a patient might have features of both systemic sclerosis and dermatomyositis. Clinical features: the clinical presentation depends on which diseases are involved in the overlap. For example, in a patient with SLE and polymyositis, you might see lupus-specific features, e.g., malar rash, alongside muscle weakness and elevated muscle enzymes indicative of myositis. Prognosis: the prognosis of overlap syndromes depends on the specific diseases involved and their severity. Management typically involves treating the individual disease components. Key differences: antibody markers. MCTD is characterized by the presence of anti-U1 RNP antibodies, while UCTD lacks specific autoantibodies, and overlap syndrome may present with antibodies characteristic of multiple diseases. Clinical definition: MCTD has more defined criteria, anti-U1 RNP, and a combination of features. UCTD lacks sufficient features to be classified as a specific disease, and overlap syndrome includes clearly diagnosed features of multiple well-defined CTDs. Disease progression: UCTD may remain stable or progress to a defined CTD. MCTD can evolve into a single CTD or remain a mixed condition. And overlap syndrome generally involves managing multiple diseases concurrently. These conditions require careful clinical and serologic assessment to guide treatment strategies. Mixed connective tissue disease, MCTD, is a distinct autoimmune disorder that presents with overlapping features of several connective tissue diseases, CTDs, most notably systemic lupus erythematosus, SLE, systemic sclerosis, scleroderma, and polymyositis, dermatomyositis. What sets MCTD apart from these individual diseases is its strong association with high titers of anti-U1 ribonucleoprotein, RNP antibodies, which are central to its diagnosis. Key features of MCTD. 1. Immunologic marker. The presence of anti-U1 RNP antibodies is a hallmark of MCTD. Nearly all patients with MCTD have these antibodies in high titers, which helps differentiate MCTD from other connective tissue diseases. 2. Clinical manifestations, Raynaud's phenomenon. This is often one of the earliest manifestations of MCTD and is seen in the majority of patients. Swollen hands, fingers. Patients frequently present with puffy or swollen fingers, which is sometimes referred to as sausage-like digits. Arthritis, arthralgia. Joint pain and inflammation are common in MCTD, resembling the arthritis seen in rheumatoid arthritis or SLE. Myositis. Muscle inflammation and weakness, similar to polymyositis or dermatomyositis, can be present. Scleroderma-like skin changes. Skin thickening and tightening, particularly on the fingers, can occur, resembling systemic sclerosis. Pulmonary involvement. Lung disease, particularly interstitial lung disease, ILD, and pulmonary hypertension, is a significant concern in MCTD. Pulmonary hypertension is one of the leading causes of morbidity and mortality in MCTD. Esophageal dysmotility, like scleroderma, patients may experience difficulty swallowing due to esophageal muscle involvement. Cardiac involvement. Though less common, heart involvement can occur, including pericarditis, myocarditis, and arrhythmias. 3. Diagnosis. The diagnosis of MCTD is typically based on clinical criteria and the presence of anti-U1RNP antibodies. Several diagnostic criteria have been proposed, such as those by Sharp, Kasakawa, and Alarcon-Segovia, which focus on a combination of clinical features, Raynaud's, arthritis, myositis, etc., and the presence of anti-U1RNP. 4. Differential diagnosis. MCTD must be differentiated from other connective tissue diseases like SLE, systemic sclerosis, and polymyositis dermatomyositis, as well as overlap syndromes, where features of these diseases co-occur but without the specific anti-U1RNP antibody association. 5. Prognosis. The prognosis of MCTD varies. Some patients may remain stable for many years, while others may progress to develop features of a single connective tissue disease, such as systemic sclerosis or lupus. Long-term outcomes depend on the extent and severity of organ involvement. Pulmonary hypertension is a particularly serious complication that requires close monitoring and treatment. 6. Treatment. The treatment of MCTD is tailored to the individual patient's symptoms and organ involvement. Corticosteroids are often used to manage inflammation, particularly in cases of myositis or severe arthritis. Immunosuppressive agents, such as methotrexate, azathioprine, or mycophenolate mofetil, may be used for more chronic disease management, especially with significant organ involvement. Calcium channel blockers, or other vasodilators, may be used for Raynaud's phenomenon, and specific therapies such as phosphodiesterase 5 inhibitors, e.g., sildenafil, or endothelin receptor antagonists may be needed for pulmonary hypertension. Regular monitoring of lung and cardiac function is crucial to detect complications early and adjust treatment as needed. MCTD and disease overlap. While MCTD itself is an overlap syndrome involving features of SLE, scleroderma, and polymyositis, it is considered a distinct clinical entity due to its unique serologic marker, anti-U1RNP. However, over time, patients with MCTD may evolve into a more specific diagnosis, such as SLE or systemic sclerosis, which complicates long-term management. Overall, MCTD is a complex condition requiring a multidisciplinary approach to care, with rheumatologists, pulmonologists, cardiologists, and other specialists working together to address the wide range of potential complications.